Thanks everyone for joining us for DDU Teaching. We are starting afresh. So the DDU exams were a couple of weeks ago. So forgive me if we're going back a little bit for some of us. Some of you have been joining these for a while, but I hope it's okay because we've got Umi, our Echo Fellow, back from maternity leave. It's great to have her back. And so we're just going to start with a little bit of LV size, function, and hemodynamic assessment, and we'll go from there. Same rules apply. I hope it's okay. If your video is on, you're fair game for questions. But they're nice and simple this week, I hope. Okay. So we'll go through we're going to talk about LV size and function assessment, particularly on how to accurately assess those. We're then going to talk about cardiac output assessment. And as we go through these, I'll try and give you an idea of when and how I use them and try and ask questions as we go. And please, as always, interrupt me. I might just, as we're starting to talk about LV size and function, I just want to show you some unpublished data that Ben Gahadi has been sitting on for over 9 months now, FYI, if Ben listens to this. Anyway, it's fantastic. So this is, I think, one of the largest retrospective analysis done of critically ill patients done. So it's part of what's known as the National Echo Database of Australia, where they take data from sort of every lab in Australia and link it up with the death registry. So you get really accurate ideas of how maybe certain parameters are linked with death. And we've obviously put our hand up to be a part of this massive study that I think has got something like 70 hospitals around Australia involved in it. And so we put our hand up for it. We obviously do a lot of echoes on outpatients as well as on ICU patients. And what we did is we took 5 years worth of data on all echoes that we'd done on critically ill patients in the ICU, and then we linked that up with local death registries. So hopefully we got, a really robust idea of how many of these patients died. And then we looked at, there was no sort of big data analysis or cluster analysis where you don't try to ask the computer to tell you the relevance between those who survive and those who don't with RV failure. You put it the other way around. You put the echo data into the system and you say to the computer, just tell me what clusters you're going to have come up and tell us which echo parameters are the most likely to be associated with outcomes. So it's a large database, and it's just shy of 2,000 patients. So I think it's bigger than most. And one day Ben will publish this data, I hope. And what was the most striking feature for me in this, and this is a little different from some of the data that we have, for example, on septic shock, is that it was ventricular function, particularly left ventricular function, that held some of the highest prognostic significance from that. And that was even higher than age. So, the worse your ventricle were, the more likely you were to die. So that is different from some of the other data that we've got. This is all retrospective in origin. It's a highly selected population who are obviously sick enough to get an echo. But it's still interesting, I think, to note that, I use this at the start of this talk to say that it is important for us to examine LV size and function. It's what we obviously look at first when we're starting to do echoes, and there's a bloody good reason for that, and that's because it is highly prognostic in the critically ill. One day Ben will publish that. It was important to see there that it's the LV, as I said, the LV was probably more important than when the RV was down, but it was, if they were both down together, that held the highest significance. Okay, so as we go forward, let's make sure that we're measuring it accurately, and let's understand that it is important to measure. Okay, so we'll start off with LV size. Couple of ways to assess LV size. First, we just eyeball it, and we got a little marking along the side of the echo image, so you can have a look at those to try and estimate whether it's dilated or not, or you can try and do an objective measurement. And the objective measurement, the way you do it is you're meant to stop the image, scroll it forward till the, how do I do this? Till just the mitral valves close for the first time. And then you measure it at the tips of the mitral valve leaflets and try not to include trabeculations. Try and find that sort of first continuous line in that wall and make your measurement. And if it's greater than, say, 59 in men and greater than 52 in women, that's dilated. If it's greater than 66 in men or 60 in women, then that's severely dilated. Okay. When I was learning echo, we always used doing this with M mode, and that's been That's not the recommended way to do that anymore because why? Yeah, what do we call that? So Umi was there if you heard her. She says the angle that we've got, like this one's a terrible view, right? If you were going to try and measure the internal diameter of the left ventricle, and that's because the angle's out. And so that what's that gonna give us?
To basically underestimate.
Overestimate. So if you imagine if it was only going to be 5 millimeters that way, if we then measure it the other way, it could be 6 millimeters, and we'd say that it'd be dilated, and it's not. So yeah, so you'd be overestimating it if you've got an angle that's off. And the other thing that we sort of talk about with M mode is that it's got this thing translational error. You know, if we're trying to measure it in perpendicular format right at the tips of the mitral valve leaflets, you get other parts of the heart that come in during there. So it gives you that translational error. But we love talking about it in exams, particularly looking at valvular function and aortic valve opening and diagnosing. Either it's always going to be, if we show an exam, it's either going to be constriction, it's going to be LVOT obstruction, or mitral valve stenosis. I generally find those are the ones that we do, and they love asking it in the ASE exams. So yeah, I think those are probably the good things for exams. It's not bad for TAPSE, obviously, of the right ventricle. That's pretty good. And it's not bad for MAPSE, that we'll talk about in a sec. Okay, so the next thing that we're starting to get on more and more of the machines is this, and certainly it's talked about in the cardiology literature, is 3D analysis. So echo machines are getting better and better, and 3D transthoracic probes are getting better and better. And indeed, I think on GE now, some of the new probes that they're coming out, they can all do 3D analysis, whether you've got that package or not. So the imaging is enticing. The images are beautiful. If you go and talk to any rep in any company, they'll show you that 3D probe and show you their image panel, and it looks absolutely incredible. And hence it's made it into guidelines where they talk about it. And that's because it's the reason why they're trying to sell it is not just because it looks pretty, but it's also shown to have high degrees of correlation, better than ejection fraction of 2D imaging versus MRI as the reference standard. And you know, incredible graphs are drawn showing how accurate it is, measuring it on 3D analysis. And so we had to try to have a look at it, and again, I couldn't exactly do it versus 3D analysis, but all I can say is that the error that I was using as the reference standard stroke volume measured by Doppler. So again, it's not the perfect way to compare it, but if I was using that, saying that generally that's pretty accurate, and I'll show you some data that shows that it's pretty good in a sec. So it's not that bad. It's pretty precise as long as you're well trained, and I hope I was okay for that. So I used that as the reference standard, and I compared 3D volumetric analysis of both the LV and the RV there. And so you can see, if you look at that Bland-Altman plot on the left, it was, you know, the errors that we'd see coming into that in terms of stroke volume assessment were sort of plus or minus 15 to 20 mils, which when you're looking at a 60 mil volume, that's quite a lot, I thought. And so it certainly, I felt, lacked precision and lacked agreement when we did this. So at the end of the day, the study which we looked at for the LV, and it was even worse with the right ventricle, where we had up to 25 to 35% mil differences in our stroke volume assessment for Doppler versus 3D and volumetric analysis. I ended up coming through saying it probably wasn't quite ready for the critically ill population. But this was done maybe, how long ago is that? 6 years ago. So maybe the machines have got better. Might be worth having a look at again. But these were in sick, ventilated patients, and it was a bit rubbish, unfortunately. Okay, any questions so far on LV size assessment? Okay, let's talk about systolic function. So when we're looking at systolic function, first things first is to never analyze it in one plane. We're going to start with an eyeball evaluation, and you look at it in every plane you possibly can. So here we've got our parasternal long axis and our short axis view. Rishi, what walls are we looking at in the parasternal long axis view?
So we are looking at anteroseptal and infralateral.
Beautiful. Anteroseptal and infralateral, very nice. And what do you think about the overall LV systolic function?
Overall appears to be moderately impaired.
Beautiful. So it's not mild to moderately impaired. It's not low normal. It's not, slightly okay or something. So again, for the DDU, let's get our language precise. I think sonographers can get away with saying it's mild to moderate, but as reporting doctors, and I think when we're talking to each other, it's important to make a call. And that's what advanced echo is all about. So you've got to say it's mild, moderate, or severe, or normal. Beautiful. And we got our walls right. So if we're looking at the anteroseptal and infralateral, that corresponds with our anteroseptal and infralateral on our short axis. So do you think there's any regional wall motion abnormalities?
Yes.
Excellent. I agree. Where do you see the regional wall motion abnormalities?
Maybe the infralateral and infroseptal.
Yeah, very nice. And then we can start to get an idea when we're using our short axis, and I'll talk about this a little bit later. We try and use that sort of 16 segment model to try and define our regional wall motion abnormalities. And we're going to try and talk about them being akinetic, hypokinetic, or dyskinetic. And we try and have an idea whether they be acute or chronic. And so, again, we'll go through this a little bit later, but normal is thickening more than 50%. Hypokinetic is thickening, but less than 50%. Akinetic is not thickening or thickening less than 10%. And dyskinetic is no thickening, and going in the wrong direction during systole. And if we want to try and figure out whether it's acute or chronic, this is what chronic looks like, where it's thinned and scarred and a bit bright. And chronic and acute is when it's normal in thickness and not bright, and hypokinetic or akinetic. Cool. Okay. So if you had to guess the ejection fraction, now you can see other views. What would you guess the ejection fraction would be?
So I would say 35 to 40%.
Yeah, not bad, not bad. I agree, and I think it's the more you do of this, the better it's going to get when you're eyeballing it. And we've also going to, of course, go on and talk about Simpson's biplane method in a second. But if we can try and remember what normal, mild to moderate, normal, moderate, and severe abnormal are, and they're different for men and women. But I have sort of cutoffs for me of about 52 and above would be normal, and then anything from 40 to 52 is mild, 30 to 40 moderate, and less than 30 severe. So let's talk about the eyeballing. So you're going to have an eyeball method to try and assess it. And then the next part is if you're going to go and do measurements, to try and make sure that that measurement as close as possible backs up your bias. I'm being facetious, but it's really easy to make mistakes with this. But at least when you're looking with your eyeball, you've got to have an idea of what it sits at. So that if you start getting measurements that are way different from what you've eyeballed, you've got to ask yourself a question, have you got it wrong or have you made a measurement wrong? And the better you get with your measurements and your eyeballing, I think most of the time it's normally the measurements that have some of the errors, in my opinion. So just every time you're doing a scan, just get an eyeball of what you think the ejection fraction is. And it's worth doing these kind of things as you're training, doing them as often as possible so you know how to do them. And it's when you need it, for example, if you're doing scans on patients who you're worried about chemotherapy-induced cardiotoxicity or something, that's not the time for you to be practicing Simpson's biplane method. You need to know how to do it properly, first of all. So, a few tips and tricks. First of all, you ignore the trabeculations. We're just looking and we're doing the trabeculations, and you ignore the papillary muscles. So you're looking for that junction between the endocardium and the lumen, and that can be tricky. If you can't see it, don't measure it. Okay, so don't force yourself to do a Simpson's biplane if you can't see the walls. The classic way we say is if you can't see two continuous segments in both views, don't do it. Okay. The next tip and trick I'll have is to measure the end diastolic length. So when you start measuring out the Simpson's biplane, you'll automatically be given that end diastolic length. And that should be within 8 millimeters of the 4 and the 2 chamber. So if they're not, then you're potentially off axis. Okay. So which once again, ignore the trabeculations, ignore the papillary muscles, and try and find the endocardial border, and then use your length. Make sure it's the same in your 4 and your 2 chamber. Okay, so let's talk about pitfalls in this. So the pitfalls are as if you're not on axis. So we talk about that being foreshortened, right? If you're a rib or two too high in your apical views when you're trying to get your 4 and your 2 chamber, you are going to foreshorten your image. And the way that you can tell about doing that, so what do you think about these? So Drew, do you think these images are foreshortened? And if they are, why do you think that?
Yeah, I do think so. The ventricle doesn't have the usual truncated ellipsoid shape.
Yeah, nice. It
Or
looks more like
bullet
spherical, right?
bullet
Yeah,
shape.
no.
Yeah, it's more circular. You can see some contraction at the apex, which is abnormal as well.
Beautiful.
And then, yeah, I guess you can see, I guess just the atria seems it's not aligned. And I know that the atria and the ventricle can be misaligned normally, but it just appears out of keeping.
Yeah, really nice. One of the little tips and tricks I've got is if you imagine I often just put my like thumb right on top of the picture. I'll sort of try and do that if you can see my cursor. Can you see my cursor okay? Is it there? Yeah, so I've just put something at the top of the image. Now, remember that the heart, if that's the apex of the heart and that's the base moves towards the apex. And it does that in a bit of a twisting format. But the apex stays fixed, and it's fixed at the apex and it's fixed at the pulmonary veins. It's sort of the back of the heart. So it's like if you imagine the annulus or the fibrous skeleton is the bit that moves up and down. So the apex should remain fixed. So if you see the apex moving, it sort of tells you that you're off axis there. So you shouldn't see that apex moving. It should remain fixed. Nice. So if you start to make ejection fraction estimates, I should have probably asked you what you thought the ejection fraction was of this patient. I think I'd probably be putting it down at maybe the 30 or 40%. Maybe it's a little bit overestimated when you start to include that apex if you've got a foreshortened image. All right. So what about this one? God, we've taken a lot worse pictures, haven't we, to be honest? Maybe I could have chosen a better example, but I think, you'd feel confident about choosing here in this, anterolateral, infraseptal wall and anterolateral wall over here. You'd probably be a bit more confident about doing it in the infraseptal wall than you would in the anterolateral wall, though. You don't know exactly where to put that line if you were to measure the ejection fraction. Maybe we're off axis a little bit. You can see that apex contracting down. It's a little hard sometimes in the critically ill. And what makes it a lot easier is contrast. That's another way of trying to improve your reliability of doing your Simpsons biplane, measuring your volumes, measuring your ejection fraction, trying to find regional wall motion abnormalities. So this, you can say with a lot more certainty where that endocardial border is if you're using contrast. And so we get these kind of measurements. You can see here that the LV length of 9.2 versus 9.9, those are nicely within 8 millimeters of each other. And you can start feeling a bit more confident about your measurements when you've got it like that. And again, there's pretty good data that shows that they correlate. But let's just talk a little bit about ejection fraction. So who's using this as part of their everyday reports? I put it into my reports. I sometimes wonder how useful it is in the critically ill, though. I think when we're talking about ejection fraction as a marker of LV systolic function, they've got these great slides, and I stole this off a friend called Antoine Herpin, so thanks for his slides. But you get this idea in like 183 patients in this study that was done, over 20 years ago now. Not surprisingly, it shows that ejection fraction can vary dramatically in terms of your cardiac index, and that's because, it's very much affected by afterload and volume status. So you can have an ejection fraction of 80% and a low cardiac output if you've got, I don't know, what do we say, septic shock with a really low afterload. Or alternatively, you can have a ridiculously high cardiac output and a super high ejection fraction if you're, I don't know, if you're underdoing exercise or you're in a hyperdynamic state from mild infection, but you haven't quite fallen over into septic shock at this stage. I think if you're on catecholamines for other reasons. What about, cardiogenic shock is obviously if you've got low cardiac output and a low ejection fraction, but you can still be in shock, as we all know, and you can have a normal blood pressure and a normal ejection fraction and have lactates that are 4 in septic shock as well. which, you know, I guess would be more in keeping with something up here. So I think ejection fraction, you cannot take it in isolation as a marker of, I think it's a marker of function. I think you've got to take it in the nuanced approach. And I guess what it can be useful for is maybe talking about maybe I'll talk about this again in a second, about some of how the VA coupling potentially is working, maybe. Anyway, and that's what this is trying to show. So I think in terms of talking about VA coupling, I guess what ejection fraction can try and help tell you is how well those two things are combining. So this is a really nice paper. It's from a few years back now, done by with Florence Boisser and Dessap's area, where they show this quite nice correlation between ejection fraction and end systolic wall stress, or a marker of VA coupling. And they were trying to combine everything from looking at loading conditions, trying to figure also out what what the afterload was doing in terms of non-invasive assessment of afterload. But there's quite nice relationship between the two. I think this is maybe what ejection fraction can try and help tell you. And so if you've got super high ejection fraction with low afterload, that can help sort of point you in the right direction, maybe, as opposed to someone who's in cardiogenic shock. So I think ejection fraction certainly can't be taken in isolation, but it can give you an idea of where else you need to look. And that's where we need to start thinking about other ways of assessing it. So other ways of assessing it, we've got a few things. So first of all is tissue Doppler imaging. So tissue Doppler imaging is where we put our pulse wave cursor over the medial and lateral annulus of the mitral valve. We're using it for diastology, but we can also use it for systolic function. You'll notice that at the edge of it, we've got meters per second when we're normally doing pulse wave Doppler, but with tissue Doppler, we've got centimeters per second. And that's because when we're using our pulse wave Doppler, like looking at mitral valve inflow, you've sometimes got this little area here, which is low flow speeds are kind of ignored. And that's anywhere from 10 to 20 centimeters a second. We ignore that because we're normally interested in flows through mitral valves of like a meter per second. Whereas with tissue Doppler, we're interested in centimeters per second. So that's anywhere from 5 to 20 centimeters per second. And from that, we can get various markers. We've got our E prime and A prime, but also our S prime at the top. And let me just talk about these markers. So Damien, just tell me if you can see my marker. Just what am I pointing at on this tissue Doppler image with my mouse?
So I think that's the isovolumetric contraction phase. So it's not a true S wave. It's
perfect. So the S wave you measure is the next one up. Have you got any tips and tricks for how to make an accurate measurement on this?
No.
Because we do it with E prime. We measure E prime, maybe an A prime, probably more often than we measure the S prime.
Without any hints or tips, I'm afraid.
No. Are you measuring using tissue Doppler? Are you sort of getting towards the diastology assessment phase?
Yeah.
Fantastic. Yeah. So the argument that I'd say is, first of all, it is still a Doppler measure, which means it's angle dependent, which means you have to make sure that you are measuring from the apex of the heart. You know, as I said, the base moves towards the apex. So make sure you are imaging on plane, first of all. Make sure you've put your Doppler cursor as close to the movement of that annulus as possible. And then when you're making your measurement, you have 3 cardiac cycles within your frame. You've got your baseline in the middle of the screen, and you've got your scale optimized, so what you're interested in filling the screen. And then the last thing to say is that you turn down the gain. So turn down your tissue Doppler button, or your active Doppler button on whatever machine it is, and just turn down the gain so that you're grabbing what's known as that modal velocity. Because if you turn the gain up, it looks super fuzzy, and you want the chin, not the beard. So the same as if you're making any other Doppler measurement. And then, as you were saying, we've got our isovolumetric contraction, and then you've got your S prime. So it's the second peak that you're measuring, and it's during systole. So systole is from the beginning of the QRS to the end of the T wave. And then the next bit is the E and A wave, E prime and A prime. And again, I could probably turn down this gain a little bit more, but you'll see I'm trying to avoid that fuzz in there. And so you've got your isovolumetric relaxation time that happens just at the end of the T wave. And then you've got your E wave and your A prime, E prime and A prime. So magic number 7.5 centimeters per second for the LV is what's normal and abnormal. Umi, give me some advantages of tissue Doppler imaging for assessment of LV systolic function.
I've mentioned one of it already, how it's independent of the load.
Yeah, and that's what it's touted to be, is a bit more load independent compared to ejection fraction. What about disadvantages?
I think the disadvantages will be possibly all the ones, like all the criteria about how to optimize it. So how it needs to be on plane,
Perfect.
the right position.
Perfect. And then the last thing is to say, talk about translational error. So anytime you're measuring like a pulse wave thing, the heart's going to swing around in it some way. So we call that translational error. So we're not absolutely certain we're actually measuring the annulus movement because it kind of comes in and out. Very nice. Okay, next one. I should mention that a lot of this stuff has been brought up in the last DDU exam, by the way. So it's really important to, this stuff, even though it feels like it might be basic, we're still asking about this. It's still important. It still comes up in the exam. So what about this one, Rishi? What can we measure on this one to try and estimate what systolic function is?
So we can measure the dP by dt.
dP dt, right? So when you've got when patients are having caths, when they used to do a lot of LV hemodynamic assessments, one of the things that they can look at is what's known as the dP dt, which is how rapidly a pressure changes over a certain amount of time. And then from that, they can figure out how well the heart's systolic function is. The way that we can guess that in echo is we look at mitral regurg, but you have to have a central regurgitation jet. And if you do have a central regurgitation jet, that means that your Doppler alignment with that jet is pretty good. And then you can start making this measurement, which is the change in pressure over a change of time. And you measure that change in pressure. You know that pressure because you're going to measure the time it takes for it to go from a pressure of 4 millimeters of mercury. So I've done 4v squared of 1 meter a second squared. And how quickly it goes up to 3 meters a second. So that's 36 millimeters of mercury. So it's the time it takes to go from 4 to 36. So, a change of 32 millimeters of mercury. And you measure that time by making a simple measurement. And if it's greater than 1,200 millimeters of mercury per second, that is normal. And if it's less than 800, it's abnormal. Okay, Umi, I would like you to try and tell me how I could have, what's wrong with this trace. So first of all, I've measured it off this patient here. What do you think of their ejection fraction, first of all? What do you think of this heart?
It's severely reduced.
Excellent. Severely reduced ejection fraction. Is it chronic or is it acute?
It looks chronic.
Okay, excellent, because the walls are thin. So we've got possible impaired blood flow to the myocardium. Anything else?
Not really.
No.
And then the signs that the atrium dealt.
Beautiful. So the atrium, particularly the left atrium being enlarged with raised left atrial pressure, it's hard to enlarge left atrium. Normally, I think we sort of estimate it sort of starts to enlarge with increased pressures after about 3 or 4 days. But having something this size, it's almost the same size as the ventricle, makes you think that it's not, it's not this patient's first rodeo. Faraz Pathan, my friend who runs the echo lab with me, he always calls it the HbA1c of the heart, which I always enjoyed. Yeah, so this looks like there's chronic impairment. It's probably severely impaired. And most of the time when I'm doing this measurement, it's either in patients who are super difficult to image, or it's sort of backing up what I was thinking when we were examining them. And this is certainly agrees with what you were saying, because it's less than 800. But how confident are you in this measurement? I don't know, have you ever done this measurement before? It's pretty easy to make this number 2000 or 2 or 20 just by moving this cursor a very, very small amount. So I think probably what I'd say to this measurement is that it's probably not that accurate when you do it like this. And ideally what we should have is changing the scale. So it's just that scale that I'm interested in, of like 0.5 meters a second up to 3.5, and then I have the sweep speed as being super long, so that I'm making the measurement, and the measurement that I'm making is across the entire screen. You've got to be able to see that line nicely, and don't try and fake this number, and don't use it in isolation. I think would be the go. Nice. Next one I'm using a bit more these days is MAPSI. So that's the mitral annular plane systolic excursion. And again, it's how this annulus moves towards the apex. All right. And it moves towards the apex, and we can measure the height difference. And the way that you measure that height, sometimes lots of trabeculations involved, is you're measuring the sort of the first continuous line that you can see after you come out of the lumen. So that's the best way to remember that. And Stephen Huang, who works here, did a nice study showing that this MAPSI correlates quite nicely with global longitudinal strain, as you'd kind of expect, and we'll talk about that in just a second. And the magic number that we have is about 8 millimeters. So if it's more than 8 millimeters, or 8 millimeters and above, that is someone who's got maybe normal systolic function, and less than that is impaired. We don't really have gradings. And what are the advantages about this? Why is this important?
It's easy.
It's easy, right? Yeah, absolutely. It's like TAPSI. So it's easy to add in. Why is it good for the LV? It's not quite as good as for the RV, but why is it not a bad measure? And particularly, why do we care if it's like global longitudinal strain? What's the advantage?
The LV contracts.
Okay, coming on to that sort of. What do you mean by that?
It's more from base towards apex.
Absolutely. So the heart and forgive me for not putting in a slide about this, but you've got maybe 3 different layers to the heart. The inside layer is the endocardium, and that predominantly has longitudinal muscle fibers that go from the base to the apex. The next 2 layers sort of overlap each other like sort of hands when you put hands over each other. It's for 45-degree angles, and that helps with that twisting function, which is really useful for systolic function. But why does it, if it then, the endocardium's the inner layer, you can imagine that's what MAPSI is trying to describe, right? That it's that longitudinal function. When you get that twisting function, it does sort of pull the heart up as well. So it is describing that to a certain extent, but it's predominantly describing that longitudinal function. Why is that important, and why is it shown to be highly significant, particularly in acute heart failure patients? Fantastic. Why does it get affected earlier?
Because of the endothelium.
Yeah, endothelium. Tell me why again.
I think just in terms of like the perfusion when your endothelium is
Very nice.
infected.
Because the endothelium is the furthest away from your blood supply. So your coronary arteries are on the outside of your myocardium. The endothelium, therefore, is the longest distance to get for those micro circulation, the blood to get to that area. So it's the ones that are most prone to ischemia. And that's why things like global longitudinal strain and MAPSI might be useful. I think it's only going to be useful versus global longitudinal strain if you do not have regional wall motion abnormalities. If you've got regional wall motion abnormalities, or you've got horrible, annular calcification, or if you've got a pacemaker in there, I think all of those things would potentially bugger up MAPSI a little bit. But it's super easy. It's shown to be prognostic, and it's probably prognostic in those heart failure patients because of ischemia would be my guess. The other thing, the reason why it's important is if you just have a look at this sort of top image here, don't worry about the rest of it for the time being, but you can see that this is an MRI study that was done in normal individuals, talking about whether the most force is generated by the left ventricle. And the most force you can see here for a left ventricle, the LV force, is generated by this red line is where the most force is generated, and that's from an apical to basal movement. So in normal individuals, that's where the greatest force happens, from a base to apex. And that makes sense because the LVOT is right next door to where the inflow is. The angle of ejection of blood is almost, up and down in terms of the left ventricle. And that's why it needs to put it in that direction, as opposed to the most force in the right ventricle, which is in the diaphragm to RVOT plane, which is more in line with the RVOT. Because if you imagine the tricuspid, because of the triangular shape of the RV, here I can draw on here, the triangular shape of the RV going from the RA into the RV, and then it's actually from the diaphragm towards the RVOT. That's where the maximum force needs to happen to push blood out of the heart, which is really interesting, I think, as opposed to the LV where it is, can I show? Yeah, LV here, where it's sort of much more up and down. And that's why greatest force apical to basal for the LV and greatest force for the RV is diaphragm to RVOT. And incidentally, remember that this isn't a talk about the RV, but I have to say it, because the RV has got a predominance of longitudinal muscle fibers. It's a bit funny that the maximum contraction is in a completely perpendicular direction to that. And that's probably because it's the RV has insertion points into the LV edges around the septum. And if you can imagine then that twisting function that we were talking about with those fibers that are in different angles, that twisting function must have a huge amount to do with what generates that RVOT diaphragm direction. You imagine that twisting function sort of squishes it over. And that's why we talk about that radial function when we're looking at echoes being so important. Anyway, talk about the RV sometime. I think it's interesting. Global longitudinal strain is just a pumped up MAPC, where we put the speckles that make up the heart, we track them, and we particularly track them in an apical view. And so this image that we can see here is made up of little dots. Those little dots are actually quite stable throughout the cardiac cycle, because as the ultrasound hits them, it scatters when it hits tiny little myocardial fibers. And those scattered waves, that's what makes up the speckles, because some of those scattered waves join with others and are destroyed, and some of them join with others and are made bigger. So you get this kind of patchy black and white speckled appearance to the myocardium, which is quite stable over the cardiac cycle. And so the machine can latch on to these, they're almost like fingerprints all the way along the myocardium, and watches how they move during systole. And from that means that we can get an idea of how these speckles move towards each other and away from each other. And so we talk about strain is what the measure is of speckle tracking echo. And it's a measure of deformation. So if you started out at being like 10 centimeters apart, and then you went to being 7.5 meters apart, that is a 25% deformation. And because it's shorter, it's a negative value. So you talk about negative 25% is a measure of deformation. The more negative it is, or the bigger that number is, that negative number is, that means a more systolic function has happened, more contraction has occurred. So the lower the number, the better. And you get these beautiful curves. So they split ventricles up from your apical 4, 2, and 3 chamber views. They split it up into 6 segments. From that, they can make your bullseye plot, where the outside is the base of the heart, around the bottom there, and there. The middle section, or the midsection, is the middle part of the ventricle. And then the apex in the middle are the apical segments. And they can show it in this nice pictorial format, so that red is normal and white is no movement and blue is dyskinetic, moving, stretching out in the other direction. And so it's maybe a nice way to pick up early ischemia, just like with MAPC. And you can also maybe describe some regional wall motion abnormalities, and can be useful for trying to describe things like amyloid or stress-induced cardiomyopathy or stuff like that. Okay. Let's talk about cardiac output. So I think in critically ill, using ejection fraction in isolation is dangerous. One of the things I'm going to try and include it with is a stroke volume evaluation. This is a really nice paper done by Philippe Vignon describing some of this. And what he's describing is obviously in cardiac output, as we all know, it's heart rate times by stroke volume. But that stroke volume is going to be affected by diastolic function, and it's going to be affected by ejection fraction. So it's a load dependent measure, just like everything else. And the lower your load, that's going to affect your stroke volume. And the lower the load, it can increase your ejection fraction, right? So when we try and include all of these things together, this is where we can start to get a picture in our mind of someone who's, for example, let's take the normal first of all. So a normal stroke volume of 60 mils, that will have an ejection fraction of 55 to 70%, and you're going to have a normal end diastolic diameter. But you can create that perfectly normally, and people are walking around with dilated cardiomyopathies when they've got ejection fractions of 20%. But they're able to do that because they get a very dilated ventricle, which means that 20% can create a massive stroke volume. What they often don't like being done is having any kind of bradycardia though, right? Because if you in any way stop that stroke, if you in any way impair, or beta blockers, they don't like beta blockers sometimes. So if you've got a dilated cardiomyopathy, someone in cardiogenic shock, beta blockade can be devastating for these patients, because if you stop any of that contraction, you will have a marked effect on their stroke volume. As opposed to, they've got HOCM here. The example I have in my head is, Mrs. Smith, who's 75 with COPD, who's got hypertension. She has very thick ventricles, sometimes got a bit of a aortic stenosis in there. She can have a very, very high ejection fraction, but because her end diastolic diameter is small, she's got a small, thick ventricle, which is often quite stiff. Her ejection fraction needs to be much higher to make a similar stroke volume. But again, she can be walking around a normal day with that kind of effect. And what she doesn't like is hypovolemia. And if she gets septic shock and hypovolemic or reduced afterload in any way, that can be devastating for her. So you can't take any of these in isolation by themselves, I guess would be my message. And together they can make a normal cardiac output, but how then you're going to manage them when they get sick can be very different. So, for example, the HOCM patient, these kind of patients with stiff ventricles, they can love beta blockade if they're in septic shock sometimes, and alternatively, those with very bad hearts can hate it, but they can, get the idea. Very quickly, just to make sure we're on the same page, how do you measure your stroke volume? Well, you're going to measure your LVOT radius. You're going to do pi r squared of that radius, and you're then going to times it by the distance of one blood flow, which we talk about being the velocity time integral. So if you're going to measure your LVOT, you do it in a zoomed up pre-processing way. So that means that you do it live. So you don't go and zoom in after you've recorded this image. You put your zoom box over this thing and you zoom in live. And then you pause, scroll through it till you're in mid-systole, till the valves are open, and you measure where the cusps enter the LVOT, and you measure it some way within about 0 to 5 or 8 millimeters from there. If you can't see it, don't measure it. Okay? If you measure it and you get a weird number, measure it again. Normal values being, Damien, what's normal LVOT diameter?
So anything up to about 2.2.
Yeah, and anything above?
Anything above 2. In terms of the lower limit, about 1.7, 1.8.
Yeah, 1.8. Very nice. So if you're getting numbers outside of that, just scratch your head a little bit. They've either got Marfan's or they're ridiculously small. Okay. Next one is the LVOT VTI. So that's done with pulse wave Doppler in your apical 5-chamber view. So it is a Doppler measure. So make sure your Doppler angle is appropriate. So you put your color Doppler box over it, see which way the blood's flowing out. An example for why we need to do this, take a dilated cardiomyopathy. As that heart gets stretched more and more, the blood flow comes through more laterally. So sort of blood comes into the heart and then comes out of the heart the other way. It's almost like doing a figure of 8. Normally it's up and down, dilated hearts, color on it, make sure you've got your angle correct. Okay. I do it by moving the image over onto the left side of the screen. If we were just to measure, if you imagine blood flow sort of skirting the side of that septum, this this white marker is how you'd normally measure your apical or apical 5-chamber view, just by tilting up from your apical 4-chamber. But you've got to rock the probe a little bit over, or fishtail the probe a little bit over, so that you actually follow the angle of interrogation, so you don't underestimate it, because it's obviously cosine dependent for the Doppler angle. Then you have what you're interested in, filling the screen. So base towards the top, thing on the bottom. Make sure you got a closing click in there, and then you can measure the modal velocity. So then turn down your gain. More and more in the DDU, where we're showing you pictures, and we might ask you to critique the picture. So I think what we're trying to inspire there is to make sure your measurements are correct. I think we've got to measure things correct, because I'm becoming more and more fond of the idea of using echo as a monitoring tool. So you've got to make sure you're measuring it the same way every time. Blah, blah, blah. I'm sure you know all this. So you take your heart rate, you've got your LVOT area. You can either, you'd get that either with the radius or the diameter. Times those together against your LVOT VTR, and you can get your cardiac output. Okay, sources of error. Who's just starting? Hey, one, give me some sources of error for a stroke volume.
So the multiple different sources. Measurement error in LVOT measurement can be incorrect. The Doppler alignment could be incorrect. Stroke volume. So that's. I mean, I think
there's
the
two main ones. Yeah. Okay. I think saying that why do you care about the LVOT diameter being measured wrong? Why is that important?
Oh, because it's squared, so the error will be squared.
Yeah. The Doppler angle. I also think about where we're putting a pulse wave Doppler gate. The reason why we talk about needing a closing click is that tells you that you're at the same place that you measured your diameter. The LVOT is a funnel shape. So if you measure it too far out, you're not going to be in the same place. So when you're measuring it with a closing click, I imagine it's a bit like standing in a doorway, right? If you're standing too far into the doorway would hit you on the back of the head and hit you in the face, and you get clicks on both sides. If you're standing just at the edge of the doorway, where the door inserts into the doorway frame, the doorway would just sort of bang you in the face, or you'd feel air coming into your face if you were just before it. And so if you're measuring, the LVOT diameter as the doorway, you want to be measuring it not in the actual valve. Because if you're measuring it too far into the valve, or you're measuring it too far out of the valve, the LVOT VTI will be artificially low or high. So if you're in the valve is smaller than the LVOT, you are in what's known as the zone of acceleration. So that means that's where the blood flows increasingly through that. If you're too far back into the LVOT, or even into the left ventricle, that's got a wider space, so you will underestimate the flows. So I always have Emma in my mind, where you put the color Doppler over your LVOT. You need to see where it starts going red as it goes into the acceleration. You want to be just behind that area where it's red of the sort of the Pisa of it is going into the zone of acceleration. So she describes it as being in the blue. The last thing to make is you've got to measure it properly. You don't want the gain too high. You don't want to have the Doppler profiles too small. And the last bit is to say that you assume that the LVOT is circular, and it's not. There's pretty good shows of where the LVOT has not got a normal shape. Okay. This is just an example of how you can overestimate it. If I make a normal measurement, I get an LVOT VTI of 27. If I make a ridiculous measurement with bad gain settings and bad Doppler profile optimization, you can overestimate it quite a lot. And it's not bad, right? There's some evidence that says in the critically ill, we've got pretty good agreement, even at low and high cardiac outputs. It's good when we look at it in terms of changes in cardiac output, particularly with passive leg raising or starting catecholamines. And again, it's not bad at low or even high changes that go on. Bland-Altman plots have changes of anywhere from, it's kind of pretty close around sort of maybe the plus or minus 1 liter, and that's certainly better than pulmonary artery catheters versus versus other things. So it's not too bad. And it's only in 38 patients, but they were a septic shock, cardiogenic shock. Most of them are on catecholamines, on noradrenaline. So I don't think it's too bad. So I think we can say it's got a pretty good precision, compared to pulmonary artery catheters. And of course, it's a really valuable part of trying to assess aortic stenosis and things like that. And you can compare the DSI between the two of them. And the reason why you need to measure this and not just use like a single measurement for an aortic valve, because like if you take a mean gradient, we know mean gradients, if they're greater than 2, that's an example of someone who's got a stenotic valve over 20, it's a mild to moderate stenotic valve. Over 40, it's severe. You've got to take into account stroke volume, because if you've got a hyperdynamic circulation, such as in this patient who's got an LVOT VTI of 33, normal being around 22, if we're in a high stroke volume states, all valve flows increase. So that's why the continuity is incredibly important, and while measuring your stroke volume accurately is incredibly important, particularly if you think you've got a patient with abnormal valve function in the critically ill. So last little bit, Drew, which one of these patients has sepsis and a hyperdynamic heart function?
Sorry, hyperdynamic heart function, you'd see a LVOT VTI diameter or VTI that would be greater. So I'm looking at a 2.5 or the Vmax. So in C, the Vmax is higher. VTI.
Well, I made this a bit hard, haven't I? I forgot to look through this, isn't it? Because you'd be forgiven for thinking, what do you reckon?
Yeah, look, usually I would go with the VTI.
Yeah, I agree.
The Vmax is oddly higher in C, but could be a flow acceleration for another reason.
Yeah, good call. You'd be worried about it, and this is someone who's maybe got a little bit. I'd be worried about A for this one, so that's why I've got raised VTI. Okay. What about this one? Who's got aortic stenosis?
Back to me still?
Yep.
So I guess the criteria we'd look at is like the AV max over, 4 is severe, so 3.4 is moderate.
Fine. Yep.
And that's probably what I would look at.
So how do we do it in the critically ill? So you've got to allow for the fact that this patient was critically ill. You've got to make sure you don't have a high stroke volume. So what was a normal LVOT VTI?
So 18 to 24.
Fantastic.
18 to 20.
So call it 20 just to make maths easy. Yep. And so we can look at that dimensionless severity index. I love that in the critically ill, right? So we can compare the LVOT VTI with the aortic valve VTI.
Yep.
And if it's greater than 0.5, it's normal. If it's less than 0.25, it's severely abnormal.
Yep.
So let's take so you compare the LVOT VTI with the VTI here.
Yep.
So that would be
0.25. No, it's
absolutely
greater than 0.5. C nice. Would be at 16 to 62. So it's
So that's the one those are the two values that then scare me. The fact that you've got an LVOT VTI that's less than a quarter of the aortic valve VTI.
Good point.
Well, it's almost a quarter. Sort of, it's on the cusp. But yeah, so that won't be the patient with severe stenosis, as opposed to B. What would B be? So give me an example of what pathology B would give you. So you've got a diameter that's kind of normal at 19. We've got a VTI that's low. We've got a Vmax that's low, normal being about 1. We've got a VTI that's 18, which is similar to the LVOT VTI, and you've got a low aortic valve Vmax. So what pathology could give you that?
Like a low flow gradient.
And what do you mean low flow gradient from what?
Some severe LV dysfunction.
Perfect. Yeah, cardiogenic shock. Beautiful.
Yeah.
So the example would be someone who's got that high VTI, it's probably better on this one, high VTI, high Vmax, but the DSI is about right, who's got high Vmaxes. So that's someone who's in a hyperdynamic state or exercising. B is someone who's got low VTI, low Vmaxes, who's someone who's in cardiogenic shock. And C is someone who's got low VTIs, high aortic valve VTIs, high aortic valve gradients, that's aortic stenosis. Very nice. We kind of went through a lot of stuff on regional wall. Maybe just a couple of tips and tricks. You've got to know your walls. I think if you're doing advanced echo, I think I've said this over and over. If you're doing advanced echo, you've got to know your walls. I love asking people about the walls of the ventricle because if you don't know it, you don't know advanced echo. So make sure you know it. This is a picture from the ASE LV size and function thing, so it's freely available. It's a really nice picture. And I always have to start with my 2-chamber. I always know I've got anterior and inferior here. And I got to my 2-chamber from rotating 60 degrees from my apical 4-chamber. Yeah. So that means that this has to be my anterolateral and infraseptal. Cool. So I'm from 4-chamber to 2-chamber. And then if I go over to my 3-chamber, that means I'm back to what looks like my parasternal as well. So that's my anteroseptal and infralateral. Cool. Nice. A lot of variation amongst patients about what coronary artery territories go to which areas of the heart. But I generally imagine if my left hand's my left ventricle, LAD is wrapped around the top. That's this blue line here. So it supplies the apex and all of the top part. So it's like my fist is there around the top. The right coronary is the one at the side. And that's the equivalent of here doing the right ventricle and inferior area. And then the circumflex is on the other side. And so the circumflex does the sort of the lateral side of the heart and the inferior portions. And there's overlap among that. The reason why I show you that is if you're starting to report regional wall motion abnormalities, it's incredibly rare to get patchy regional wall motion abnormalities. You don't really see that except with like something like Chagas disease or something, right? So if you think that you've got like a hypokinesis here and a akinesis over there, it doesn't make sense. You know, normally it is in a regional wall motion. It's in a, coronary artery distribution. Okay. This is another way to think about it. Again, there is overlap between them, but just think about all the different views and what coronary artery territories affect which areas. Okay. If we're going to be precise with our language, that means that we talk about it being normal, hypokinetic, akinetic, or dyskinetic. There is no mildly hypokinetic. There's no severely akinetic. Okay. So just thickening more or less than 50%, not thickening or not thickening and moving in the wrong direction. All right. The tips and tricks I'd give is to start recognizing the walls that you're looking at, and then you don't make the decision based on one view alone. For example, here, if we've got the inferior and anterior, and which coronary artery territory do we think is affected? LAD, because it's the top part of the heart. If you think it's like that, go and check it out in other views. And the go-to view I have for going to check things out is my short axis view. It's often the hardest one to mess up. You know, you can often be off axis and things in your apical views. So your short axis is often the best one to look at. Okay. Hey, what abnormality are we looking at here? Which artery?
Maybe it's just my computer, but sorry, it's just a bit jumpy.
No
that's
problem.
my excuse.
Can anyone say a little bit about it? Yeah, sure. What I can show you is that it looks like we've got the anterior or the septal area looks like it's thickening. Anterior and inferior looks like it's thickening. And it's just the lateral that looks thinned and bright. And so that would be in keeping with someone who's got circumflex chronic ischemia for me. Okay. And that's about the same. Right coronary can also be affecting the right heart. So one of the last tip and trick is if you're not using it for regional wall is using the subcostal short axis. After you've looked at the IVC and that sort of longitudinal plane of subcostal, just fan the probe over so you're looking at the short axis of the heart. So here we're imaging through the left ventricle, but you can still sometimes get quite a nice short axis of the heart. which will be a nice way to think about trying to back up any view of abnormalities that you might have seen elsewhere. So just to go through the tips, use every view possible to have a look at it. You get 2 or 3, even 4 goes with different views, having a look at a single segment. So if you think you've got somewhere that's abnormal, go and look at it in other views. My go-to view for going to the checkout, if there's any regional wall motion abnormalities, your short axis. Use your subcostal short axis as well. Think about acute versus chronic. So chronic is thinned and scarred and often akinetic. Acute can be hypokinetic or akinetic, but it's not bright and normal thickness. And the last thing is if you think that apex is akinetic, you've got to go looking for clots. And that's where in critically ill, in hypercoagulable state, you can think about clots up there. And we'll talk about that when we talk a little bit more about LV function. Thank you very much for listening. Haewon, you had a question.
So it's a quick question. When you see like a septal bounce, I mean, obviously that's not what you would, that wouldn't make you worry about coronary artery disease. But I mean, would that be dyskinetic, or do you just call that like?
Yeah, really great.
Septal bounce?
It's sometimes hard to do it, and pausing and rolling through it can be useful. The other thing is actually just putting M mode over it in your short axis view when you've got the septum in the axial plane, if you like, if I got that right, in the axial plane rather than the lateral plane. And then you can look to see if it's thickening during the cardiac cycle. The bottom line is that the septal bounce can make looking at regional wall motion abnormalities difficult, but it still thickens if it's normal. Okay.
Sure.
So just because you've got regional wall motion abnormalities does not mean that you've got ischemia. It doesn't mean that you've got akinesis. It does mean it's a lot harder to assess.
Sure. Okay. Thanks for that.
Yeah. Any other questions?
Just one question.
Sam, can I just ask a really quick,
Yeah.
silly question about MAPT and TAPSI measurements?
Sure.
So I've kind of just heard varying opinions on whether you measure slope or perpendicular in terms of your peak to your trough.
Why would you measure slope?
As in
you're saying that you'd
you-
measure the distance
whether
would
you
be
draw
from the start to the top, because it's M mode. You've got to measure distance, which is always up and down, right?
Okay, sure.
Does that make sense? Because it's about a movement, so it's got to be measured in millimeters. So because the M mode is distance over time, if you measure the slope, it's kind of an estimate almost of speed.
You're
isn't
going
it?
to be prolonging it. Yep.
Yeah. So you've got to
Okay.
be, but to be honest, but the other thing to say is it's actually quite hard on M mode to measure the slope. I think you're probably measuring the same thing in M mode, whether you draw it from there to there, the value it still gives you is in millimeters. It's still measuring it on most machines as being the distance. So it doesn't matter where you click, even if you imagine the screen is the M mode, it doesn't matter if you click there and click there, it's still measuring a height that's that.
Yeah, that makes sense.
So it's
thank you.
I think it's if it says it's in millimeters on an M mode image, it's still just measuring the distance. It's not measuring the speed.
Yep. So it doesn't really matter where you place your cursor. It's just still giving
exactly
you
right.
Yeah.
So I think it's actually pretty hard to measure the slope and speed on M mode.
Yeah, no, that makes sense.
Rishi had a question.
Yeah, just with regards to the VTI,
Mm.
I've had a lot of problems with clinicians making a call for management decision changes based on VTIs, especially in cases where there's discordance between the ejection fraction and the VTI, especially because as it is a load dependent parameter, pre-load dependent as well as after load dependent. I've seen cases with like heavily low after load with severe reduced ejection fraction, having relatively better VTIs.
Yeah, great question.
And then patient weaning the dobutamine,
Yeah.
and the patient landing up in trouble later on.
Yeah, wow. Did you guys hear that? I think it's a really important question. I think it's going to come back to a philosophy that, I love echo. I think it's amazing. One of the things that worries me is, and I'm sure we've probably all seen examples of where echo has caused harm. And it causes harm because we haven't integrated an echo finding appropriately into a clinical scenario. So I think we must be using our clinical acumen and then using echo to kind of back that up. And that's the, I've got that saying in my head, if the echo can make a good doctor great and a bad doctor dangerous. I think if you're taking any single echo parameter as your absolute marker, you can get into trouble with it. And the example is going to be cardiogenic shock, isn't it? Cardiogenic shock and using LVOT, VTI in isolation. I think it can be reasonable to do it based on a VTI alone, because the VTI, as long as you're measuring it appropriately, it's not limited to, a measurement of LVOT diameter or something. So we can use it as a surrogate for stroke volume. But just the same as we've seen, there's great examples of trying to outcomes for septic shock patients based on cardiac output. Cardiac output, we've known that that's not a marker we should be aiming for. I think that's because stroke volume it doesn't describe contractility. It's a combination of afterload and preload and heart rate. It's a combination of everything. So you've got to take it into control. And if you got someone whose stroke volume has increased, that either means that their heart rate's gone up, their contractility's gone up, or their afterload's gone down. And if you're looking at stroke volume, you're looking at a combination of all of those. So therefore, you have to assess all of them. You've got to look at contractility, which is anything that we've measured there, including ejection fraction, MAPC, S prime, eyeballing. Maybe, I think global longitudinal strain is probably research-based, but also afterload. And afterload is lactate, clearance, feeling their hands, cap refill, change in urine output, change in, pulmonary edema or whatever. I think so. You've got to take that clinical stuff in with the echo features, and you can't take stroke volume by itself without assessments of preload, contractility, and afterload.
Yeah.
But I'm really interested to hear everyone else's thoughts, because, I think that's the way it should be done. So just got to have your head on a swivel. Does everyone agree with that? I mean, I think that's right.
Can I say one thing, Sam, that perhaps the VTIs are within normal range in a normal person, 18 to 22, that perhaps a septic patient or someone else requires more stroke volume in order to meet the adequate perfusion.
And it's going to vary, right? Because again, it's dependent on contractility and afterload.
Which I guess brings me to my question, or request. Are we going to have some education on ventricular arterial coupling?
Yeah, the answer is I was going to try and do that today, and I ran out of time. I got to be honest, I'm not an expert on left ventricle VA coupling. Is not something I use a lot. I think probably from the reasons that I've just said is that the afterload, I think, is a clinical assessment as much as anything at the moment, and feeling patients' hands and looking at things like fluid status and everything is in there. But there are colleagues and there's data out there where they talk about it being the be all and end all, a great way of doing it. And so, how about I promise I will do something. I think it's probably quite research based, and I was meant to do it today, but I ran out of time.
That's all right.
I'll look into it. I think it's really good for right ventricle VA coupling, though, is amazing, and that is important, and that's much easier to do. And I think we've discussed that in the past, but I'll discuss that again, and I'll try and get better at it. Do you know a lot about it, Drew?
I've started to read around it a bit, because I feel like it's along with Vexus, one of the last pieces of the puzzle to the assessment of the full circulation.
Well, do you want to talk about it? Do you want to do a presentation for DDU teaching sometime, even just like 20 minutes, half an hour, whatever you want?
I'd love to.
Oh, that'd be amazing. Oh, well, let's talk about that, and we'll pencil you in. That'd be excellent. I'll get Tara to reach out, and we'll find a time.
Yeah, I'd be honored. Yep.
Thanks, Drew. Cheers, mate. Thank you. Any other questions?
Do you ever use the E-point separation?
Oh, well, so did you hear that? So do I ever use E-point separation? Yeah, I mean, so E-point separation is that anterior mitral valve leaflet, as long as it's not rheumatic, there's not horrible stenosis, you don't have horrible mitral annular calcification, how well it opens, so how far that anterior mitral valve leaflet reaches towards the septum. And the magic number is 7 millimeters that they've talked about. And as long as it reaches, less than 7 millimeters, then your cardiac output is greater than 4 liters. So it's something that I might talk about in an exam, to be honest. If they show me a terrible functioning heart in parasternal long axis, I'll skip past it. I don't start with that, but I do look at it. It is a marker of bad cardiac output if the valve's okay. And yeah, I should have had that in there. But it's not something, again, it would be like a layer on top after everything else. Looking at ejection fraction, eyeballing that, MAPCs, things like that. Okay, thanks very much, guys. I'll see you guys. I'm not here next week. I'll find someone to cover, and I'll see you the week after. Cool. Thanks very much. Bye.
Thanks very much.